Also hier muss ich auch sagen, also
Markus will talk in German. Well, Markus has been out of Germany for at least 2 decades. He says his German is like German in kindergarten, actually. But I can tell you his German is quite well. So this is a world premiere for Markus to present in German. So no, he'll do it in English. Now what? My name is Markus Renno. I'm living in the United States. I've spent all my life almost in the United States, but my father is German. He's from Stuttgart, and he studied at the University of Stuttgart, and then he got to know my mother during an exchange program with the United States. She was a teacher of German, and that's why I'm here now. So he lived in Sersheim near Stuttgart, and I lived there for 2 years when I went to kindergarten and to primary school. And this is why I can tell you I can answer your questions in my kindergarten German, but I will hold my presentation in English because I think that's much easier for me.
All right, so just to mention how I got started with myotubular myopathy. I am currently a pediatric cardiology fellow at Vanderbilt Children's Hospital in Nashville, Tennessee, but I did my pediatric residency at the University of Florida, and while I was there, I worked with the team at the University of Florida, including Barb Smith, who's sitting in the back and has a talk later today, one of the workshops. And we worked a lot on looking at the respiratory function of kids with centronuclear myopathies, and this was just published a couple months ago in Muscle and Nerve. And so that's where we really started, was looking in depth at the respiratory function of kids, but over time our research is growing, and I'll explain a little bit why. We're also now looking at quality of life. To frame this, I think as Dr. Lawler just explained, it's important to have information as we have new therapies on the horizon. It is important to know what does the disease process look like in every dimension that matters, and how can we quantify that, and how does that change over time for most people, so that when we do something new, if we have a new therapy, we try something different, we can actually say, yes, this did change something, or yes, this changed it by this much. If we don't have this information at the beginning, it's really hard for us to know if anything new that we do actually makes a difference. So I've got kind of a challenging topic, I think, because quality of life is not exactly clear, and it's not the same thing for one person to the next. Quality of life is by nature very subjective. It's what you think is important. It might be very different than what the person sitting next to you thinks is important in life. And it probably is very different than what I think is important in life. Quality of life is colored by your culture. It's colored by your experiences. You know it when you feel like, my life is good right now. You also know it when you feel like, my life is not that good right now. And so it's just a very difficult thing, I think, to measure. And let me give a few examples from what we've learned from kids with CNMs. The first one is tracheostomy. It's often one of the first questions that comes up. How do we best support our child if they're having difficulty breathing on their own? Do we do this non-invasively? Do we do a tracheostomy and support them with the ventilator through the tracheostomy? For some families, the decision is that you do the trach because it's easier, it simplifies things. But for others, they worry more about the infection risks that we know are present when you get a trach. I think it's important for me to say this at the beginning. I'm hesitating to get to data first because I think this is very important for me to say first. There is not a wrong answer. there's only the right answer for you and your child. And so anytime I go into a clinical encounter, I try to hold no judgment. I think it's important that we as doctors share as much information as possible with each family, but that ultimately that decision is for that family to make, because their values and their culture and their experiences are probably different than the last patient that I saw. And so they need to be able to make that decision for themselves. Another example that we have noticed a lot in our breathing studies is that families wrestle with how much time to spend fully supporting on the ventilator. Some families feel like, I want to keep the breathing muscles as strong as possible, and so I'm going to have my child spend more time not fully supported, or spend more time off the ventilator during the day. That keeps their muscles stronger and might make it easier for them to clear an infection if that kind of thing were to come up. And so that's important to them. But then on the flip side, there are other families and other children who aren't able to tolerate that as well, and who become too tired to be able to communicate or to be able to play. And so for those families, the calculus might be very different. Those families might choose to just be fully vent supported, because that's what makes their day better. Gastrostomy is another example. Some find it just makes life so much easier to make sure that the calories get where they need to go. Others find the process of, I know that with my German family, eating is so important. We sit down for our big meals together, and eating is so important. And so sometimes it might be hard to say, let's do it. We need to do a gastrostomy. So families wrestle with these questions, and they're hard. Whether or not to attend school, it's another great question. Do you want your child to be a part of, have life as normal as possible? It's a wonderful sentiment. Of course, there are risks of going to school, because you're exposed to other children who might be sick or have a cold, and so these are questions that families wrestle with, and so I put all of this out there because I think it's important to recognize that when we talk about how we're going to measure it, it's not that we're saying that this is necessarily good and this is necessarily bad. It's that we're trying to figure out ways to measure what are the things that are challenges that a lot of families experience, and how can we then come up with some outcome measures that we can use when we're planning clinical trials, for example. So, so I've talked about why we should try to measure it. I think enough. It's just that as these trials come up, we need to have this information. It's incredibly important that we have quality of life information. It's incredibly important that we have breathing function information. It's important that we have ability to walk and strength information. All of these things are data points that we're going to need to figure out what are we going to use in these clinical trials coming up. So we've talked about what quality of life is and why I think it's important. But before diving into the data, one last thing that I want to mention is how are we going to measure it? There is a tool that has been developed. This is the tool that we used for our data collection. It was developed in patients with Duchenne muscular dystrophy and with SMA, spinal muscular atrophy. But it asks a lot of the same questions that really are generalizable to all neuromuscular diseases. There are 17 questions about my neuromuscular disease, and some of them like, it's hard to breathe, almost, always, often, sometimes, never, and it asks in the past month, how often is this a problem? Communication, it has 3 questions about communication, and then it has another 5 questions about family resources, and the family resource questions are about how easy is it to take a vacation, how easy is it to get resources, medical supports like a ventilator or a chair and those kinds of things. So it tries to, the survey tries to ask a broad spectrum of questions about what might affect the quality of life and what a lot of families struggle with. So And one last thing, limitation of our data, before I show you our conclusions from our data. Number one, it's a small sample. I'll tell you about that in just a second. And number two, the sample that we have is probably biased to some degree by people who are more optimistic about life in general. They're the ones that are traveling to conferences. They're the ones that are participating in research studies. So they may tend to be a little bit more optimistic about things. So this may not represent everyone. It also doesn't include any of the babies who might not have made it past their first year. So what have we found? We surveyed 14 patients with X-linked MTM. So we've only collected so far on X-linked MTM. And 11 families actually completed the quality of life inventory. The boys ranged from 7 months to 19 years. Most of them were between 4 and 13 years old. Quality of life scores were similar in most of the categories between X-linked MTM and Duchenne muscular dystrophy and SMA, somewhere in the 50 to 60 range. But there was one exception, and that was the communication category, where the MTM boys had scores that were significantly lower. They were mostly in the 20s compared to the SMA and DMD kids, which were closer to 60. I'm not putting specific numbers up here or statistics because with small sample sizes it doesn't necessarily make sense, but we're just starting with this data and trying to draw some conclusions. So we did ask ourselves, why is that? Why do we think that the communication score is so much lower in MTM compared with the other two populations? And one thought that we have is that the need for tracheostomy and ventilator is probably a little bit higher in MTM than it is in the others. And so maybe it could be that that is one thing that is a barrier to communication. And then the last thing that we found is that quality of life scores do not always correlate with disease severity. There was one example of an outlier that didn't fit into the data like I would have expected. He was 13 years old. He was mildly affected in comparison to most of the others in the group. He was ambulatory for most of the day except for very long distances. He was able to talk in full sentences. He did not need a tracheostomy or a G-tube. He did have a non-invasive ventilator to help with breathing while asleep, but otherwise was very mildly affected compared to the others. But his scores were actually right on average, maybe even just a little below the average for all the categories, with the exception of communication, and where communication for him was the same as DMD and SMA. So I think that also kind of supports what I just mentioned before, which is with him not having a tracheostomy, his communication score might have been better than most of the kids with MTM. But I think it also highlights another very important point, and it's kind of what I started with. It's that everyone has different perceptions. In quality of life, it's as much about how you perceive your situation as it is about what actual limitations you have. So for him and his family, it was equally profound for him to need the smaller amount of support than the other kids, but it was equally profound for him as it was for the other kids who were more affected. So what are the conclusions that I want you to take away from this talk? Number one, I think it's important that medical teams do spend some time focusing on helping affected kids communicate with loved ones and caregivers in this MTM group. Our sample is not very big, but I would say that with the information that we have, it seems like it's a general general challenge for a lot of people, and so bringing that up with your medical team is probably a good idea. The second thing is that a quality of life survey is also probably something that would be helpful in the clinical environment. Talking to your doctor about potentially doing a quality of life survey, that might be helpful. One reason that I say that is that there are some studies that would suggest that doctors who take care of people who have a tracheostomy, they would rate the quality of life of that patient lower than the patient and family themselves. Okay? And so doing a quality of life inventory may actually help them to better understand where you are and what you are worried about most about your child. And then finally, as I mentioned, quality of life data will be something important that we include as we go forward studying the effects of new treatments as they become available. We need to have this information to be able to make conclusions about it. It would be great if gene therapy fixed a lot of things, but if it doesn't change the way that people perceive how good the life is of their child, then who cares? So I want to also close with one final thought, and that is that every time that I've come to our meetings in the U.S. And coming here today, I am always blown away and reminded. It's amazing to me how everyone loves their child no matter what in their own way, and it's a reminder to me to do everything that I can to love the people around me, and that includes you guys. So thank you so much for letting me come and join you today. I have to acknowledge our team as well, especially Barb Smith, who's sitting in the back, and Lee and Stephanie, who worked in our lab to kind of help me look at this data at first. So I would be happy to answer any questions.
Thanks a lot, Markus, for this very informative talk. Any questions for Markus? German or English? He's taking everything. Questions for Markus? Yes, over there.
Lebensqualität dieser Kinder.
Quality of life of these children and of their parents. Everybody makes their own decision on that, but there are children who go to school. How can these people who surround the patients, like parents, how can you explain them that they have a quality of life that should be respected? Well, that is a very difficult question. Well, but I think it's a key question to us. Yes, it definitely needs time and patience. You have to work together, the families and the teachers. There has to be a lot of communication. You have to speak to the teachers and explain to them that, so in order that they feel comfortable being around the kid. Don't you think there should be more information? Because in my experience, which is a while back, but there are stigmata with parents, with teachers, excuse me, who say, but this kid is probably stupid because he's not able to partake like the other kids, but the kid itself shows that it's not true. Well, and we have seen that the intelligence levels are the same. That is a big topic that the teachers have to understand. It takes time. These people have probably never seen a case like that, and that is why it is so important to speak openly to them and also be understanding that they haven't seen a case like that before, that they take some time. But it is a very good question. But if you want to reach an understanding, then I think time is of the essence. I don't know, could you generally speak about our school systems, the differences between the US and Germany? I know that there is individual care in schools. I don't know if that is the case everywhere in the country. Here in Germany, there is a completely different question that has to be asked, because children cannot be homeschooled. We differentiate between different types of schools, supportive schools or normal schools. We like to separate everybody into groups. Could you just say one or two words how it is different in the US? Well, I don't know that much about the situation in Germany, but I think you're completely right. In the United States, it is much easier to have a homeschooling situation where parents or agencies can help. Often kids with major disabilities can be homeschooled and can also get support from the government. But personally, I don't know the German system that well. So unfortunately, I can't say too much about that. It's just a question of standing together, and if there is a problem in Germany, that it's a problem that needs to be addressed and need to be worked on. Is it a general idea that these kind of surveys are made at a larger scale? Because I think it makes a lot of sense. Quality of life is an essential factor, and there are kids who have track care, some who don't. But quality of life itself is what it's all about. How can you communicate this to hospitals that they take this into account, both in the US and in Germany? Well, our neuromuscular diseases clinic that we have in the United States, this is a place where it is easier if you specialize on something like that, then it is easier to just do surveys like that. It's more difficult for a system like it is in Germany to have a survey for a relatively rare disease such as this one. For example, doctors or hospitals, it's hard to remind them to do this regularly. Special clinics, special hospitals are probably the place to do it. But the problem in Germany is there a lot of specialist centers, and almost any university hospital, any large hospital has something like that. There is also a difference between Germany and France. We have been traveling with Professor Reut because he was focusing on our son Luca, who had MTM, and who did the biopsies. There is a major difference. In Germany, there are no possibilities to get into discussions with doctors. Lucas does not have track care, but he does get a breathing mask overnight. Unfortunately, the German system is just not set out for these types of cases. The key doctor has not been able to come today, but there isn't consensus on how to proceed with his case, because in Germany it seems that everybody just wants to pass on responsibility. There are also some cases where the doctors want to take a decision on surgery, for example, but the parents are not sure. What can parents do if you have a hospital like that, a specialized hospital? Could you please get in touch with this hospital in the US? They have done surveys. They know what it's about. This would be so much easier also for care workers, because suddenly the doctors can have a more general image of the family. Well, the PedsQL software that I've seen does exist in English. I'm not sure if it exists in other languages as well. But it could be introduced to hospitals and it could be translated. Personally, I have just done my I just finished my training for children's doctor, and it's one thing that a lot of the time you see patients where you just don't completely understand, especially as pediatric. You want to do the best for the child, but it's very difficult if you can't diagnose perfectly the situation of the child. That is why I think that it's important that you here as parents are the best group of people to look out for the best of their child and to make sure that your child gets what he needs. As a pediatrician, when I see cases, I would love to look at these cases in more time. I think this could help if you're able to communicate this to your pediatric. I think that the doctors would take the time, they wouldn't refuse to look at it.
Jim, quick question. This might be a nice time to plug the standards of care document. And I know that both My Tubular Trust and the Fraser Foundation put a lot of effort into creating a parent and general clinician friendly document to help navigate the clinical care system for MTM and CNM. So I think those resources are available online, and for sure this could be really helpful for dealing with when systems aren't aware of different aspects of the condition. So,
are they available in German?
Sounds like we have a task, right? Okay.
Vielleicht jemand, der besser als Kindergartendeutsch.
Yeah, I think English and Spanish.
Should be someone speaking German better than I do.
So.
Okay, great. Levi? We have to...
I just have one more question. And I know you've only had a few MTM samples, so maybe this is from the DMD or the SMA community. Have you learned about even non-medical or non-invasive things that are helping with quality of life? I'm thinking about adaptive toys, about different communication apps. Are you collecting or creating any resource around that?
Unfortunately, no. That's not a part of the tool. The tool is really intended to help drive what medical resources are best focused for the patient and family. So that's not something that's looked into. That's not to say it's not worthwhile.
Okay, great. Thank you very much, Markus, for your presentation.